2024 is here, and so are new federal rule changes on prior auth regulations. Kicking into implementation in 2026, these rules are set to improve patient provider communications and are all about passing clear information on denial reasons and appeal processes. Running a healthcare practice in the US remains complex and challenging. It requires expertise in a variety of areas beyond just providing quality medical care. We are doctors, business managers, finance experts, and patient advocates all rolled into one. We battle insurance complexities, staffing shortages, and troubleshoot daily challenges in patient and revenue management. Hello and welcome to the Efficient Care Podcast, a one-of-a-kind podcast series that brings you conversations with healthcare practice owners and innovators where we deep dive into their journeys and business learnings over the years. I'm Shruti Mehrotra, Head of Marketing at Aarogram. In this episode, I had the pleasure of speaking with Dr. Singh, a renowned sleep specialist with 14 years of experience at the Indiana Sleep Center. He's not only an excellent clinician, but also a TEDx speaker, educator at the local medical university, and author of the book Sleep to Heal. During our conversation, we delved into the implications of home sleep tests, proliferating the field of sleep medicine, price transparency with patients, and about the rewards of being truly patient-centric. Here's Dr. Abhinav. Oh, welcome to the podcast, Abhinav. Tell us a little bit about yourself and your path to sleep medicine. What sparked your passion in this field?
So sleep medicine was an accidental discovery, not for me, but the field accidentally found me about 22 years ago. So in summary, I didn't choose sleep medicine. Sleep medicine chose me. I came to the States about 22 years ago as a research assistant in the School of Public Health. So I was studying for a master's in public health and needed some funding support with my tuition, and applied for a bunch of research assistantships to support that, and also work on a project for the graduate degree. And the first people who called were the Center for Narcolepsy and Sleep Research at the University of Illinois. And the rest is really history from there. I had no knowledge whatsoever about sleep. Medical school has a dearth or a scarcity of sleep lectures. And here I was. So studying sleep research, helping patients run their research protocols, and in exchange, I was getting funding for my public health masters, with the eventual goal of landing up in the World Health headquarters in Switzerland. That was the goal. And of course, it didn't work out that way, but maybe something better happened. And loved the field, loved how the science worked, recognized the power of this field, which is really going unrecognized. Completed 4 years there, finished my medical residency, did a fellowship in sleep medicine, and for the last 14 years, I've been with the same practice since training in Indiana. So that's my path. Love the impact it has. And my eventual goal was to do something in medicine that has wide-ranging impact. That's why public health, right? So public health, you can make policies and interventions and vaccines and improve health of the society. And guess what? That goal is still intact because I'm just delivering it through the power of sleep. And sleep will do that. Nobody has come back in the last 20 years, Shruti, and come back and said that, oh, I'm sleeping better and I'm so upset because of this. I want my old sleep back. No one, right? So you can improve almost everything and every aspect of their health with sleep. And that's why I still do it.
That's lovely. You talked about your sleep center and you've been with them for the last 14 years. Can you tell me a little bit about this practice? How is it set up? And what has made you stay there for 14 years?
Indiana Sleep Center. It was established in 2007, a few years before I got there. And it's a part of a multi-specialty practice. It's a partnership with a local large hospital. And the goal was really to provide academic level care outside an academic environment. So, and to educate the community. This is on the southern edge of Indianapolis. And this became sort of the mission was to make it sort of the flagship sleep center of that area, serving that geography. And I still believe we are working towards that mission. My sleep practice is a subspecialty practice in a larger practice. So we have about 7 sleep physicians board certified, myself included, kind of the anchor of the practice. I call myself, trying, and the others do other things as well. They have other responsibilities such as hospital, ICU, pulmonary. We used to have a psychiatrist as well, and we are training a couple of nurse practitioners very carefully to support us and patients. So that's how the practice is set up. And we enjoy the confidence of a lot of our referring primary care physicians, subspecialty physicians, cardiologists, and take care of these patients. Essentially, my goal was it was a sleep center where I joined, but I really wanted to make it a sleep clinic. I wanted to diminish the presence of the sleep center, and I wanted to expand the presence of a sleep clinic. So, in the eyes of the people, I wanted them to look at us as not the sleep center, but oh, yeah, let's send them to the sleep clinic. So, they'll meet a human. The human physician, clinician will decide what next, testing, not testing, take care of it from start to finish. And you talk about operations, right? So, I wanted to be a one click forget sort of a referral. Oh, sleep apnea, insomnia, any sleep disorder you pick, refer to the sleep clinic. They got seen, evaluated, tested, treated, followed up, and then they are back to the referring doc, all taken care of and doing better. That's what was my mission and passion, and I'm still trying and edging towards that.
You guys also offer HSTs at your
Yeah.
practice. How has that impacted your business?
Yeah, so the home sleep apnea testing was around 2010 was becoming it was being validated as a tool for patients who we suspect sleep apnea in, and moderate to severe sleep apnea, and we are very strongly suspecting. So in that group it was validated, and it was a great advance, I feel, to the field. And in 2012 it was widely adopted nationwide. And then, yes, the first step was that our reimbursements are going to shrink, because of course it is reimbursed lesser than a center based sleep study. But I think it was an essential tool for the field to move forward, because for a couple of reasons. One, it brought a lot of patients out of the woodwork, because many wouldn't even bring this up with their doctors because they would fear the sleep lab and the environment and the expense and the experience, and they would just be very apprehensive, so wouldn't bring it up, right? The physician community would also fear, saying, oh my God, who wants to do this cumbersome sleep study? It's expensive. They're not going to be able to use the machine, the CPAPs. So forget it. So there was a lot of barriers that were preventing people from getting treated. But the home sleep apnea test actually made sleep apnea diagnoses accessible to even non sleep clinicians, because they could understand this. It was a simple enough test, validated, and they could order it conveniently with less expense and get some sort of a starting point diagnostic number, right? So that way, at least it improved the diagnostic access, I feel. However, it did not, and I may be saying this a little bit tongue in cheek here, I don't think it improved the adherence or the success of outcomes or treatment. But
That
that
was my
was, I
next
think,
question. I was
yeah.
wondering, like, has that improved the patient adherence to treatment plans, or do you think it has become more
In
complicated to deal with?
it has not. Yeah, in my humble opinion, it hasn't, because they still need that educational piece which is missing. It's like you order something off of wherever, and you do something on like a DIY kind of thing, right? Do it yourself thing. There's few professionals involved, and if you just do the testing piece alone, I think the success in adherence and outcome and compliance is still not good. um, Test fail rates are high many times. Patient awareness of why they're doing this, what does the result mean. There are a lot of nuances in that interpretation, because that number that spits out of the home test has to be interpreted with lots of caution. The first biggest problem is, did they sleep, did they not sleep that night? How is the signal quality? Who is reviewing the data? Is it all machine scored, tech evaluated, physician seen, all of that, right? So there's a lot of nuance there, I feel, and too many patients get prescribed the home test and they're not good candidates for the same. So that's the other problem, right? So heart patients, lung patients, oxygen dependence, strokes, there's so many other things, other sleep disorders may be overlapping, and then they get pushed to a home test because of payer mandates or patient preference or referring doc, choice, and it doesn't end well. So it's a great tool, but it's being overused, I feel, in the short term. It's being overused, and we're not getting good results in the long term for these patients. That's my point on that. And yes, I feel the business impact of that, for sure, of course. I mean, we every sleep center, if you just look at it as a diagnostic operation, of course, suddenly you had this other alternative that you had to furnish, and we offer that full service. uh, but what it did was, this is what I tell people, that the folks who were sort of in it to win it, those labs, they closed. The labs that were not labs but were parts of sleep clinics where there were physicians and taking care of patients, those have still been doing well, surviving, because what it does is it brings people out, so you have more to test. Now you've widened your funnel of referrals. Okay. And then
Right.
the home test is not a golden shot in the arm that solves all the problems, does it? It
Right. Makes
doesn't.
sense.
And it's only meant for severe sleep apnea, moderate sleep apnea folk. That's it. So tests will fail. Guess what you do after that? If your home test apnea says no sleep apnea, are you going to stop there? No. Then you will persuade the payer or the patient to then do the proper gold standard test. So many nuances. I'm excited about the home test actually. Bring it
Right.
on.
And
It's helpful for the field.
right. And at your sleep center, your goal is to take care of your patients from A to Z, right? You want them to get better
Correct.
and then stop seeing you.
Right, exactly, especially the insomniacs. And then we see them, once a year. If they're stable sleep apneic, we've helped them through the journey of diagnosis and adherence once a year, once every other year, really for fine tuning, if that.
Shifting the gears to more operations based queries that I have, what do you think about patient price transparency? How do you deal with that at your clinic? And how do you think that has impacted your revenue operations? Because a couple of years ago, the No Surprises Act kicked in. You are obliged to be transparent about the pricing that the patient is going to be facing at the end of the treatment. How do you deal with it? You said something about you were talking earlier, and you said that you encourage your patients to clear up their dues upfront, right? Tell me a little bit
Yeah.
more about how you deal with it at your
So,
practice.
as we are partnered with the large hospital system, they help us a little bit with this aspect, and for us to stay in 100% compliance with the act, and patients have access to their pricing on their plans. And many patients, Shruti, will hear their pricing on their particular insurance portal, so they will also get an estimate of different facilities, of what charges they'll are bound to experience, and see if they go to different facilities. So yes, we have done our part, and I think so have the other hospitals. So it's like you pick a procedure, and it'll tell you, okay, if you have insurance, product X, it'll tell you if you need a sleep study at this hospital A, B, C, D, E, F, or lab A, B, C, D, E, F, these are the estimated charges. And so it's helped us. And I don't think we've encountered a patient who says, oh, I love the physician here, Dr. Singh, but I can't do my study here because you guys are charging too much more. So I think there has been some equilibration in the markets, and I don't know exactly what, but it's not that somebody's charging 5x and somebody else is charging 1x, so it's not that stark. I feel 5 years ago we would have a few calls to the lab saying, oh, I can't come here because you guys are charging. And we don't decide these prices, because the way our structure is that our partners help us with some of these negotiations, and I don't really have too much say in fixing a price as a clinician. But it's helped. It's I haven't had any problems or loss of volume because of this act. So that's my answer.
Correct, correct. And so, what do you think about patient financial clearance? What have you identified as the biggest bottleneck in patient scheduling, particularly, in your opinion?
Yes. So once the patient has had a sleep consult, and we believe in sleep consult before test order. So 10 years back, everybody would order a sleep study, right? And then that becomes into variation in notes and clinical history and incompleteness, leading to device coverage issues. And so it was just becoming very hodgepodge. And then at some point, and I was very firm in my belief that every patient needs a consult. Okay, so like, I'm not going to send a patient directly to a cardiac cath lab, am I? No. I would want them to see the cardiologist first. So why would I do that to something as important as sleep and sleep apnea, which can have wide ranging or just as much impact over time? So I said consult first. Everybody got mad, like, no, how can you see all these people, they have the same story, all of them? I said it doesn't matter. It's the same story for the doctor. It's not the same story for the patient, because they are experiencing sleep apnea at different ways, right? So they need to hear how the sleep apnea impact is hurting their life and health. Some are very sleepy, some have heart issues, some have diabetes control issues, some have driving and focus and mood dysfunction. Not everybody has everything, right? Do you see all the colors of the rainbow every time in full throttle? No. So you've got to, so that I felt consult first helped us a lot. So once they heard the story of, oh my God, all this is because of my snoring and sleep apnea, or my insomnia, or me not sleeping well. Oh, yeah. That was the first piece that led to improvement in show rates. And we've seen this in our own operations. When they see different clinicians and styles of, in different practices around the city, they'll say, oh, nobody ever told me this. Oh, I never, I just went straight to the sleep lab. I didn't even know. I was going to see the doctor after the sleep test. All these little variations of how people get the sleep test. And I said, no, 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 stop. So consult first helps the patient understand and gets more investment from them to follow through. Second, when they know they have a face they've connected with, and I say, look, you don't have to worry about these results. We'll meet after the results, and I will break out your PSG on the screen and share it with you, what these numbers actually mean. There are tons of numbers on a report. How are they going to know what? And then those seeds, which are painful actually operationally to keep doing for every patient, then
Right.
lead and put a foundation of good adherence down the road. So that's how I feel we have separated ourselves from the surrounding areas, that we invest a lot. It sounds like repetitive stuff as a clinician, but for the patient, they're hearing it for the first time. Every patient is going to hear their story for the first time, right? How this is connecting. So that's helped us, I feel, in these. So those were the bottlenecks. The big bottlenecks are no shows, not scheduling, canceling. Patient says, oh yeah, I'm not going to do this now, I don't have the time, all of this. Oh, my knee surgery is coming up, my other things take precedence. But if they'd heard from the doc, then they would push it up the priority list. So that's one big bottleneck that I feel, improved in their scheduling show rates.
Here at Aarogram, we care about um, patient adherence a lot, and it always gives me a lot of joy when I hear that there are practices out there that are doing it comprehensively. They're taking care of the patients, and it's very hard to do this and follow through on what you described without good staff. Which leads me on to my next question, which is the fact that U.S. healthcare is facing a staffing crisis. How are you navigating this issue at your practice, and what are the biggest challenges you face whilst training new staff or whilst hiring them, and what are you doing about it?
Yeah, you nailed it, right? You just hit it right on the head. Yes, very hard. So we had, first of all, the pandemic led to volume issues, right? Because labs had to close and recover from that acute attack of, let's say, throughput pressures, because patients couldn't come, everything was on pause. Then when we got back, we didn't have staff. Staff either retired or moved on. So we were doing everything like you were thinking that we were. So staffing agencies, ads, word of mouth. And there was a shortage, like every sleep center had 4 openings. So bonuses, incentives, quality of life, trying to be competitive with pay scale revisions, all of that we went through, and fairly, to keep sort of ourselves competitive. And what we were offering, staff, whether it's your front desk, whether it's your authorization person, whether it's your HSAT daytime tech, whether it's your nighttime tech, a good working environment place. And the knowledge that you have 7 8 clinicians in a large practice, who will always help with volumes, right? So in terms of volume, all kinds of volume. So if they are dedicated to helping the patient, the byproduct of that dedication is that the sleep lab gets a steady flow of referrals and volumes. So that's what I think the staff who's going to sign on sees, that like, okay, this is the guy, this is the team, this is the practice. Okay, they've been around since 2007. There's And they care about the patient, and this is an important aspect. So they don't feel that, oh, we're going to lose our jobs, the home test is going to take over, we won't be needed, those sort of things. And the second thing is cross training. So every tech, cross training into the home sleep apnea test world. Then we had some research that we got involved in to not invent ourselves. It walked in, um, and we that also protected some volumes, right? So then staffing was, we could offer that to the staff. We were testing some devices and other things. Some new pharmacological molecules were requiring some sleep testing. So it was interesting. So you have to invent yourself and diversify, and not just rely on one stream of revenue.
A little bit older, is Gen Z starting to trickle into the workforce at your
Oh,
workplace
you
as
said
well?
it. Yes, I want to say, very begrudgingly, I say yes. And by and large, we've been okay because we probably live in a little bit of a country part of the US. But boy, they have been. And we
Yeah.
treat, our staff as we treat our closest, friends and family. We try to, and they feel that. And so that's how we prevent this Gen Z-ness from coming, because we try to
Right.
keep them connected. I think the biggest problem is isolation. With this Gen
Mhm.
Z, they are on their own and they're scrolling through their screens, and it's so fragmented. They don't have a meaningful relationship or five that they can list for you. They don't, outside of their family, outside of the
But
immediate parents. I don't think they can pick 5 names.
they're also very passionate and about their work, and with the right mentorship, I think I've seen at many workplaces of my own that you can really, that if you want to find someone who's really excited about the work, it's got to be a Gen Z, if they are, motivated enough. So that job falls on us. I think that is our job. Make sure that we retain the new wave of younger folks who are joining the community, and I feel like the sleep medicine community is very small. So
Yeah,
retaining
yeah.
this generation is very important, I think, as well. What are your thoughts on revenue leakage at your sleep centers? Revenue leakages is when you miss out on catering to the right volume of patients, or when you miss out on, when you're so caught up in the paperwork that you're
Mm.
unable to schedule patients at the right time, or maybe you have some space in your clinic that's unused for at night, or let's say some nights there's no patient coming in, or in the morning there are certain labs that are only working at night and not operational in the morning. So something like that, along those lines, if this is
I
making
see.
sense.
Correct. As much as I can share, we always look at this. We try to repurpose how we can make that a 24-hour operation. And the way, because we were structured, remember, from 2007. So there are some anatomies in the lab that are legacy, and we are in the process of seeing how we can increase our utility of that space and overhead, first of all. And second, as far as losing patients and not being able to schedule them, that rarely happens. So we still take pride in trying to expedite our insurance approval first. From the point of receiving the referral, we check with the patient, like, hey, we got a referral from Dr. Singh's office, are you ready to go for this? They'll say yes, and then we put a timeline in front of them, like, okay, this may take about 10 business days for insurance authorizations. We'll be in touch again, and then we'll find a good suitable date for you, and match you with a tech availability slot, and off we go. And then we keep in touch. I think the first thing is communicating with the patient in a personal way. That helps reduce leakage so that they won't cancel, they'll show.
So,
And
what
trying
channels
our
do you
hardest.
use to do this? What channels you use to keep in
We are
touch with
still
patients?
right, still a little old school, so it's mostly phone calls with emails, phone calls and emails, and some texts, not much. And we have a portal that's functional, and so they can also see some updates there. But mostly it's one person calling them and hearing the same voice through and through, and that I feel helps. And we've had lucky to have, our front desk, who's really been the backbone of this. She really takes care of the patient as if they're the only one she's talking to all day, and she makes them feel like that, and then they also appreciate that.
Heard this theme before from other sleep center managers as well. The more pleasant the lab is, the more personable the staff is, the more likely it is for the patients to adhere to the treatment that you want to offer them, which is
100%.
yeah, which is something that checks out. I love that you are so passionate about sleep. Tell me a little bit about your book, please. You told me something about 360 degrees of sleep awareness. Tell me what that
Yeah.
is.
So let me go with the second question first. So the 360 degrees of sleep awareness was born out of this hunger, seeing so much of clinical time is spent by so many doctors in so many specialties, and sleep is rarely brought up. And very well knowing that it really impacts almost every pathology you can think of, and we can find a paper that says, yeah, good sleep helps that, poor sleep hurts that. And you name it, and I'll dig one up for you. That wasn't happening enough. And being in a community setting, I asked myself, how can we add to this? And it is also a mission of our sleep center. So we went about by saying, okay, good, this is going to be on all of us. So wherever we meet, whoever you meet, patient, family, friend, um, grocery store clerk, you name it, your drive through checkout person handing you your meal. I mean, this is a bit extreme, but literally has happened, that you will talk about their sleep. Hey, how do you sleep? You'll bring up what you do, and immediately you see the eyes light up and there's a question. Oh, so what do you do? Oh, I'm a sleep doc. Oh, really? Hey, I have my mother, my aunt, and they go on. Oh, they have a machine. Oh, they don't sleep well. And that's how it began. So I started doing a little bit of teaching at a local university. They offered a position. I took it. So now I'm teaching sleep medicine to fourth year med students as an elective rotation, teaching at the local residency program. And that you have to do, I feel. Once you teach these young minds, and you talked about Gen Z, you put these young seeds of this and they see it live in your clinic, because it's a unique rotation. They don't get offered this commonly across the country. They take that with them, like, wow, this thing touches everything. And that seed, now you plant, what I call in my 360 degrees is this: you plant a sleep eye on the back, on the front, on the sides of your forehead. It's like a cave lamp, and it lights up, so they're always looking for sleep, and it becomes habit. And the academy took notice, and they've featured this concept in their montage, like everybody should be doing this. So you talked about passionate techs, passionate front office, right? So all of them know the basics of sleep science, and they will tell the patient, like, oh yeah, you're doing this because this will help your blood pressure, this will help your mortality, your mood, you'll feel better. And so it starts there. Every touch point will explain this. And so now my wife just almost walks away. As soon as somebody says, hey, so what do you do? She looks at me and says, I'll be in the car, I'll be home, I'll see you, because she knows it's an hour gone from there. So
Yeah.
that's the 360 degrees of sleep awareness. And I couldn't be happier. And that led to so many examples that I was giving patients about how sleep is affecting them in their language, meaning if they're a plumber, a painter, a pilot, a driver, an engineer, a physician. And I was telling them, like, this is how poor sleep is hurting you. And all of this finally found place into conversation, which patients kept asking, so where's your book? So where's your book? And I kept telling them, read this book, read that book, read that book. Where's your book? So I said, every time I say, wait, where is my book? Yeah, where is my book? And so 2 years ago, a good friend of mine, Charlotte Jensen, and I got together, and she said, yep, let's do it. And we put a book together. It's called Sleep to Heal. It's on Amazon, and it really puts together a general starting primer about how sleep affects health. And it's based on real world patients that I've looked after and how their lives changed. And everybody can identify with someone in the book.
Yeah, is it easily readable by non-clinicians as well, for your
Absolutely.
patients as well? That's lovely.
100%. My daughter, who's 11, read it and says, "Yeah, I get it." And she actually read it, and she's featured in the book as well.
That's a sign of great
And
writing as well. If readable
yes,
by a young girl, young
yeah,
child.
and people have read it, and I want it to be readable by everyone. It's a fun book. It takes you through it's like a story, being a
Right.
little bit about me and mostly about sleep.
Now I'm excited and I want to read it as well. So
Yes, you tell me how you found it.
I would love to. I will really get back to you when I'm done with it. I have to pick it up soon. At Aarogram, we believe that being efficient in our business as a healthcare provider also means providing more patient-centric care. Therefore, we ask this question to every guest on our podcast, and this is a fun one. What's the most ridiculous, ingenious, or witty way in which you have solved a workflow problem in your healthcare setting?
So it may not sound very witty, but what I've firmly believed in is, patient education. I just love that. I want to see the twinkle in their eye. Okay. And I'll tell you another thing, the patient has to laugh. I know, call it corny, call it whatever you want. The patient needs to laugh before they leave the room. Okay, simple. It's
Right?
very simple.
Yeah.
Somehow, and if you make it a contextual joke, meaning, and I always tie it in, almost should write a stand up routine for this, right? So, they're tense in your room. They've come to this somewhat begrudgingly, somewhat pushed by someone, their spouse, their wife. They're getting, elbowed to the couch because of the snoring, or they're having a heart issue. And they're sort of tense and unhappy. They've heard about people with machines, for example, sleep apnea, not using, like, oh my God, I'm going to get this bad sleep study, this uncover. Oh my. So they're already that stressed, right? So, and they're seeing a doctor who enjoys going to a clinic, getting vitals taken, getting height, weight, and sitting, and like, oh God, what new thing are they going to tell me? So that, I think, once you make them laugh and they understand the problem and they have a laugh piece in that, there's a twinkle in the eye, and they walk out saying, I like that clinic. I'm going to do what they say because these guys care about me. And patients don't care about how much you know, but they know how much you care. And that is, I feel, the backbone. Yes, it doesn't translate into measurable revenue. You cannot put an ROI on this. It's hard. But I think it's the essence of what we do in healthcare. Remember, healthcare, the last part is care, right? So if there is no
Right.
care, there is no health.
That's lovely. That was a beautiful hack. I'm so glad that you shared your time with me today. And I hope our listeners pick up your book. I'll share a link of the book in the description of the episode as well. Thank you so much, Abhinav, for being with us today.
Thank you, Shruti. This was a pleasure.
This episode was brought to you by Aarogram. Thanks for listening to our podcast today. If you found this episode helpful, be sure to subscribe to our podcast and leave us a review on your favorite platform. And if you have any questions or comments about today's episode, we'd love to hear from you. You can find Aarogram's LinkedIn and website address in the description box. Thanks for tuning in.